Welcome, everyone. This is the inaugural Artificial Intelligence Survey in Latin America that Rayos Contra Cancer is conducting in collaboration with MAIA Labs based at University of Texas Southwestern. This is a project that we started last fall to investigate the current resources and needs in Latin America surrounding potential use cases of artificial intelligence solutions. Rayos Contra Cancer is a nonprofit organization whose mission is to improve sustainable access to high quality, timely, and affordable treatment for cancer patients in limited resource settings globally. I'll spend just a few minutes to go over some of our preliminary survey results before handing off the microphone to Dr. Steve Jiang from University of Texas Southwestern, and he will deliver to us a presentation about artificial intelligence in radiation oncology. Our survey had 77 participants from 16 countries throughout Latin America. We invited participants from both public and private centers, and here you can see the distribution. About half of the centers were public. We asked about what were some of the obstacles in providing radiotherapy, and as you can see, some of these were related to personnel versus resources. And the overall distribution, the 62% had to do with personnel constraints, whether it was too many patients, a shortage of physicians, a shortage of staff, or inadequate training. We asked what was the largest obstacle, and you can see that about 50% of these were described as a shortage of care providers. And second to that was struggles with inadequate training and then outdated equipment. So then we went into studying what's the workflow at each of these centers, each person responding for their corresponding center. And we'll walk through this all the way from CT simulation through contouring and treatment planning. So with simulations, we asked which technologies are used, and 65% of participants use CT scanner for all simulations, and 90% included CT scanning as part of their simulation process. This is the average sim to treat time. Now with contouring, just a quick overview. Most of the structures are contoured by attendings and residents, although you can see in some cases there are therapists, oximetrists, and physicists involved in the contouring. For organs at risk, this is a distribution of how many organs at risk are contoured for each of the major cancer subsites. And we also collected information about how long does contouring take for each of these sites. In terms of who contours the target, this was mostly the attending and residents, but again, you can see that there is some overlap amongst the other cancer care professionals. We also collected information on how long contouring the target takes for each of these sites. In terms of who does the treatment planning, we do see a distribution that includes all of the professionals, not just the dosimetrist or the physicist, although the physicist most commonly did the treatment planning. 3D is the most common type of treatment that is planned, and about a quarter of the centers use IMRT or VMAT. Treatment plan use, for those that did 3D treatment plans, most common was 3 to 6 beams. And then for arcs, most were 1 arc or 2 arcs, but a few were greater than 2 arcs. Which percent of patients received brachytherapy with LDR versus HDR versus pulse dose rate? It looks like right now in Latin America, most brachytherapy is performed with high dose rate. And for IMRT and VMAT, we see that the greatest use cases are for head and neck cancer, as well as lung and prostate, CNS. For breast, you can see the distribution accordingly. And for SBRT, we see that this is mostly used for lung cases and a little bit in prostate. and CNS, about half of the centers are using some form of SBRT for CNS when they do use SBRT. And then this has been a very quick run through of the survey, but I want to give a lot of time for Dr. Steve Jiang to talk about artificial intelligence. But we asked, which cancer site is in need of technology improvements? And the biggest desire for technology improvements in terms of how can we improve the care we provide to patients was in head and neck cancer, with 63% of respondents indicating this. We asked, what is the second biggest need for technology improvements? And for there, it was prostate cancer, followed by lung and CNS. So thank you to everyone. And now, without further ado, I will stop my sharing of the screen and let Dr. Steve Jiang from UT Southwestern and founder of MAIA Labs present his presentation on artificial intelligence in radiation oncology.
Well, thank you, Ben. So can you guys see my talk?
Yes.
So it works? Okay. So my name is Steve Jiang. I'm the vice chair here in the Department of Radiation Oncology at UT Southwestern. I'm also director of the MAIA lab. So I'll start with a brief introduction to AI. So start with this deep blue. Let me move the okay. So in 1997, IBM, there's some sort of automatic. Okay. In 1997, IBM's Deep Blue supercomputer defeated Garry Kasparov, right? The famous chess player or master player. So at that time, people were thinking, well, chess is very simple, right? Computers can do that, can do a very good job. But what about Go? Go is considered the holy grail for board games for AI because it's very complicated. It has 10 to the power of 172 possible board configurations, which is a much bigger number than the number of atoms in the known universe. So at that time, people thought it would take many decades for the AI to be the Go player. But less than 10 years, AlphaGo from DeepMind, which is part of Google, beat Niso Tao, who was considered the best player in the last decade. And then a year later, beat Ke Jie, who was the #1 player at that time, last year, or 2 years ago, I'm sorry. And then he was playing, he was crying. So basically, at that time, that was the last game between AlphaGo and any human player, because after that, the gap between the computer and the human player became bigger and bigger. Then it became not meaningful to play for AlphaGo to play with human players anymore. So then they DeepMind published a paper in the same year, announced another version called AlphaZero. So basically, what AlphaZero can do is it can play against itself. It did not need to learn any tricks from human players. By playing against itself, it will learn every tricks and actually even more than what human players can do, and can evolve very fast. Like if you look at this, basically start from zero, knowing nothing about the Go game, and then just in a few days, 3 days, it will pass the ability of AlphaGo knee, and then in another 2-3 weeks, I think 3 weeks, it will just pass the AlphaGo master. Then it keep growing and becoming better and better. So very impressive. So AlphaGo is considered a good example of earlier version of general AI. General AI is something that can learn by solving learn to solve any complex problems without needing to be taught how. And it's like AI agents. They don't need to be pre-programmed, and they can learn automatically from their raw inputs and reward signals from the environment. So that is the the ultimate format of AI. It's called general AI. But right now, most of the AI work, most of the AI models we see right now, it's called a narrow AI. It can only be trained, taught to do one thing. AlphaGo is kind of the first step towards the general AI. They actually did, DeepMind did something several years ago, much simpler, but you can see this has some interesting feature of general AI. So this computer game is called Breakout, Atari Breakout. It's a very old computer game. I guess you guys probably never seen this before because this is too old, right? This is an Asian computer game. When I was young, I played with this. So the idea is there's a little ping pong ball, there's a panel here. You just bounce the ping pong ball to this wall, trying to, every time you lock off a brick, and the goal is to lock off all the bricks in the shortest time. So several years ago, DeepMind trying to train an AI agent to do this. So the AI agent started without knowing anything. You only tell the computer three things. One thing is you can move this thing left and right. Second thing is there's a computer screen here in this kind of color. You know, each pixel has a color value. And then the third thing is there's a score, and your goal is to get this score as high as possible in the shortest amount of time, right? So those three things, that's what the AI was told. And then, of course, oh, I don't know what happened here. And then at the beginning, you know, the computer didn't know how to play or what this is about. You know, there's no idea what I should do. So it missed out a lot of the ping pong balls here, right? But the interesting thing is after about 2 hours, it became an expert. It caught every time the ball, right? And then he can, you know, just like an expert human player. But then it is even more interesting that after another 2 hours, you learn the important trick, that is to dig a tunnel through the wall to send the ball on top of the wall, so between the ceiling and the wall, so the ping pong ball will be bounced back and forth between in this limited space, like here, like right now, right? Then you can get the very high score very quickly. So I learned that, you know, playing this maybe after a few days, but the computer learned this trick just in 4 hours from scratch, right? So it's very impressive. It's a simple computer game, but it shows what AI can do. So AI is changing the world. It is everywhere now. This is how you know, I drive to work and back home every day. Tesla, self-driving, right? It's quite reliable. It makes my commute much easier. AI is also going to transform healthcare. I was interviewed by Time magazine early last year, so there are a lot of articles out there about how AI is going to change healthcare. Right? You can read some. According to Andrew Ng, he was a former professor at Stanford and one of the major researchers for AI. And he said AI is the new electricity, just like electricity 100 years ago, how electricity transformed the world. AI is going to transform our world in the coming next several years, according to him. So I'm even more optimistic than him. I think narrow AI, the one we use now, is kind of like electricity. But general AI or AI, or it's called AGI, artificial general intelligence. We don't have it now, but when it comes, that is going to be something very big. Could be dangerous too, right? So, but it's going to be very, very powerful. So why all of a sudden we talk about AI, right? Why AI is everywhere now? Number one, we have very powerful computers, GPUs, cloud computing, and we have deep learning algorithms. We have big data. We have a lot of big data now. So what is AI? There are many definitions. There is the one I like. So basically, AI makes it possible for machines, computers, to learn from human experience and then adjust to the new inputs and perform human tasks. So basically, there are three major components. You can learn from the human's experience and data, and then you can continuously learn by interacting with the environment. And then eventually it can perform humans' tasks better, faster, cheaper, right? So actually this is important feature of AI. So you might have heard about machine learning, deep learning, AI, and wonder what's the difference. So this is their relationship. Deep learning is part of machine learning, and machine learning is part of AI. And then deep machine learning has three major categories. One is called supervised learning, which is test driving for classification, for regression. And then another one is called unsupervised learning. It's called data driven. You don't have labels in the data, but the computer can still do certain things, such as clustering, dimensionality, reduction. The third category is called reinforcement learning. That's like AlphaGo. The computer can learn to react to an environment. So supervised learning is probably the one you have seen a lot. It's very popular. It's just like mapping data from A to B. It's no, in my opinion, it's no different from this kind of simple linear regression model. Here you have two parameters to fit, and in a deep neural network, you have tens of millions of parameters to fit. If you have big data to fit this model, then it can be very powerful, such as this earlier work from Stanford. You can use AI to classify skin cancer, but you need a lot of data to train a model. And this is a work from Google Research. You can use AI to detect diabetic retinopathy by looking at the retinal images with very high accuracy, high sensitivity, and specificity. Another work from the same group, Google Research, by looking at this kind of retinal images, AI can tell you a lot of information about this person, such as the age, agenda, smoking status, SBP, BMI, all these kind of things, which is amazing, right? By looking at this, how can you tell this person's age and gender, right? So AI can be very powerful if you have a lot of data to train a deep neural network. Another work from UC San Diego, similar work for using OCT, again, a lot of data. This is also Google Research using EHR to predict medical events. If you look at that, a lot of data, a lot of patients' data. UCSD again, using EHR to predict pediatric disease.
La solidaridad con las personas en situación de
Someone say something? So these are like high profile AI work in medicine, and if you they publish this kind of work in Nature, in Science, JAMA. There was a recent one published in Nature by Google DeepMind again. It's about actually breast cancer screening, mammography screening. They claim it beats radiologists. So you see a lot of this kind of work, but this is not, it does not cover all the AI in medicine work. So there includes medical imaging type of work, segmentation, reconstruction, diagnosis work, treatment solutions recommendation, care delivery optimization, automation, safety improvement, outcome prediction, toxicity prediction, individualized precision medicine, patient care in resource-limited regions. That is very relevant to RCC. Medical error detection and prevention, assisted care, and chronic disease management with wearable sensors. So those are some examples how AI can be used in medicine. In radiation oncology, in my opinion, AI can greatly improve the treatment outcome and reduce toxicity by providing more precise cancer detection, diagnosis, staging, more personalized and precision treatment strategy, more accurate target delineation and organ segmentation, better, faster, more precise treatment planning and delivery, and more convenient, frequent, accurate patient follow-up. AI can also greatly improve patient safety by automatically detecting and preventing medical errors and using wearable sensors and real-time localization technologies. Also, AI can greatly reduce disparity in radiotherapy by transferring high-quality care from major academic centers to underserved patients through well-trained AI software tools. So those are the potential applications of AI in radiation oncology, in my opinion. And at UT Southwestern, we started the MAIA lab, Medical Artificial Intelligence and Automation lab, in July 2017. So currently we have about 10 faculty members and 40 students. And our mission is to innovate, develop, and apply AI technologies to empower clinicians, especially those with less experience or limited resources. So our goal is not to develop something to replace physicians. We're trying to help physicians with AI tools. And the first aspect is to improve accuracy by retrieving hidden information from patients' data, images, and for performing likely a better job than most physicians when there is ground truth in the data. So a good example is that Google's work with the retinal images, right, to predict cardiovascular events, where human doctors can be very, how do I say, difficult to do something like that. Another important task for AI, and this is what we are focused on, is to improve efficiency by automating clinical procedures, saving physicians time in front of computers. So if you look at the survey we did, number one, if I remember correctly, number one challenge in Latin America is too many patients, lack of enough physicians. That's where AI can help, I believe. And the third one is, that's also, I think, is relevant. When you have less experienced physicians, then AI can help them by learning from the more experienced physicians, then transfer the learned expertise, knowledge to them, right? So we are trying to improve radiotherapy, improve healthcare in general through those three things. We do a lot of things. We have published probably 40, 50 some papers now, but I just want to give you a few examples of what we do. Tumor organ segmentation is one thing. You know, if you can do automatic organ segmentation, then AI can save you a lot of time, right? Also, tumor delineation is challenging. For example, we treat a lot of brain mets patients at UT Southwestern using gamma lab. So some patients have like 20 brain mets. And if you manually contour each met, it takes a lot of time, right? So we train the AI agent to do this automatically. And this moment, we're trying to implement it in the clinic right now. Another one is for like prostate. This is just an example for prostate, bladder, rectum segmentation. You know, we can do that. Uh, Another interesting example is sigmoid segmentation, which is not easy because it has complex 3D shape, has large variation among patients, and also a connection in 2D CT slice is not so obvious, right? So if you use a regular segmentation, AI segmentation method, it won't work. It will confuse AI, which part is sigmoid, right? So then we developed a method by mimicking human doctors. How humans do that? Humans will look at their previous CT slice. First, you start from the rectum, then you move up slice by slice, then you move down, and you do this back and forth. You always use previous slice and the segmentation there to ensure the connectivity, to ensure what you're doing on the current slice makes sense, right? So we train the AI model using the same idea, doing this looping inferior, superior, and back and forth, multiple runs. So it works quite nicely. This is our results, compared to brute force AI models. You see great improvements. Another interesting work we do here is for CTV delineation. In this case, it's post-op prostate radiotherapy. It's interesting because the organ is not there anymore. So yeah, you don't have like a boundary of the organ to use for the computer to segment the organ, right? You have to use information from surgery reports, pathology reports, pre-operative MR imaging, and a lot of information beyond images. And then you see a lot of variation among physicians, right? So how do you do that? We found out, let me show you this. We found out, for example, we look at 340 patients at UT Southwestern, contoured by 4 physicians. So what we did first step is we trained a classification model, meaning like you gave me a CT image, you gave me a CTV contour, and then the AI can tell you which physician did the contouring with 90% accuracy. So that means each physician has his or her own style, and the AI can learn this style, can tell which one has what kind of style, even though difference is not that big, but it is there. It is there. The difference is still there. So then we can train a general model using all physicians' contours, and then we can adapt the model to each physician's style to get the results that you like. So the idea is, if we train a general model using all physicians' contours, and then if we deploy this model in the clinic, nobody's going to like it, because this AI is going to give you some kind of average segmentation, right? And then you look at that and say, hey, this is not how I segment, how I contour CTV for my patients. And then you try to edit it every time. And after maybe a while, you will say, that's too much. I don't want to use this AI. It's not so helpful, because every time I have to modify the contours, right? So our proposal, instead of trying to tell physicians what to do, our proposal is, so have you heard of IA versus AI? AI is trying to do the jobs for you and eventually replace you. IA stands for intelligence augmentation. It is not trying to replace you. It is trying to help you to do your job. It's always an assistant to you, not to try to replace you. So we use this IA. We think this is the way to go. IA is the way to go for medicine, not AI. So we use this idea here. So we're going to train a CTV segmentation model using whatever data you have. Of course, the model is not going to be perfect for you in that case. When we deploy the model, we'll find out how many physicians you have there, how many physician styles you have there. And then we're going to adapt the model automatically to each style And then when you segment a new patient, you can choose the model you like, meaning there will be a menu. You can say, okay, there's my style, AI can do my style, or AI can do my colleague style, or AI can do UT Southwestern style, or MD Anderson style. You can choose from the menu whatever style you like. And the good thing for that is, number one, if you are quite strongly believe your way is the best way to treat patients, to treat this patient, then you can choose your model. If you're not very sure, then you want to see how Stanford would treat this patient, you can choose their model, right? So I think by providing this kind of AI tools, we, number one, can improve the efficiency. You can always do your way, or by looking at other people's approach, eventually you can learn from them and they can converge to something more uniform. So how many more minutes do I have? Is that 20 minutes?
We have 20 minutes.
Okay. Another type of AI work is image conversion. So this is one example, right? You may want to know the lung function when you treat lung cancer patients. You may want to know how the lung function looks like using the ventilation image. You may want to preserve the healthy part of the lung, right? Give more dose to those not so healthy part. So you want to have this kind of ventilation image. But it's not very easy to get this kind of ventilation image. You have to use MRI or SPECT. So we developed a model, AI model, by looking at the breath-hold CT scans, inhale and exhale. Because from these two images, you have the ventilation information there. And we can train an AI model to retrieve this kind of ventilation information and generate a ventilation image, which is very similar to your real image, right? So this is quite an interesting work for lung cancer radiotherapy. Another one is for, people are talking about MR-based treatment planning. If you already have MR, you may want to skip the CT SAM so that you can use MR to contour the tumor organs directly. But when you do the planning, for those calculations, you still need CT for the correct electron density information. And this work is to convert CT, sensitize CT directly from MR so that you can skip the CT simulation. And we use the AI model and we get to the sensitized CT, which is very similar to your real CT image. And then if you look at the plan, there's no difference. We're also trying to convert cone beam CT to CT so that you can use that directly for your planning. And we got a very good results. Actually, I got an email from Washington University today. They want to use our model for their adaptive radiotherapy. We have done a lot of work for treatment planning using AI. So the first work is to predict radiation dose, the optimal radiation dose for this patient, by simply looking at the patient's anatomy without doing any planning, optimization, those calculations. By looking into this patient's anatomy, AI can tell you the optimal radiation dose should look like for this patient. So the idea here is patients of similar medical conditions should have a similar relationship between optimal radiation dose and also patient's anatomy. And the AI can learn this relationship. So that's the idea. So if you look at this prostate MRT case, by simply looking at the bladder, rectum, in this case, there's prostate here, rectum, bladder is here, femur is. By looking at their shape and locations, AI can predict, okay, this is how the plan should look like. And this is a real plan. And you compare it to, the difference is quite small, right? So we did this for prostate, we did this for head and neck. Head and neck is more complicated, but it's still, if you look at this, it is still similar. This is the AI plan. Again, what the AI did was to locate the anatomy of this patient, then say, okay, this is how the plan should look like. And then you look at the real plan, it looks very similar. So at this moment, we are translating this work in the clinic, and we're working on the eclipse. So the idea is after encountering this kind of AI plan, AI predicted dose distribution will pop up. And then the physicians and the symmetrists can use that as a guidance. Then they know, okay, this is how I should plan this patient, right? They don't have to, wonder, what I should do. This is good enough. Should I keep working on this? They have a reference now. Then we also did this for lung cancer patients, again, MRT, because there you have all kinds of different beam angle setup. We incorporated beam angle information in the model, which can generate a very good plan. Another thing we were working on, we got good results, is even for the same patient's anatomy, but different patients, also for different physicians, you may have different preference of the trade-off between the tumor coverage and toxicity, also between different organs. You may have different trade-offs. How do you incorporate this kind of desired trade-offs in your model? So we do that through the desired DVH curve. We put that in the model, and we train the model for post-MRT. So here is an example, right? This is the same patient, same anatomy, but you may have a different desired DVH curve, which is the solid line here. The solid line is your desired DVH. Of course, in real clinic, you don't have a desired DVH, but you have desired those volume constraints, right? So you have that. So we use the solid curve and also the patient's anatomy as input. We can predict this dose distribution, which has the DVH curve in dashed line, right? Which is very similar to what you want. And then you give different solid line here as input as what you want. Then the model can predict different dose distributions with different trade-offs in dashed line. So this is still early work. We're not ready to implement this in the clinic yet, but it shows AI is capable of doing that. Another interesting work we're doing here is to use deep learning AI for dose calculation. And we found out this is not only possible, this is actually quite good. It can be accurate and fast, So like here are some examples. Deep learning based dose calculation versus reference. You see actually very good, agreement between the two for prostate and also for lung cancer, right? For lung cancer patients. So for lung cancer here, what we did is like a booster, using AI as a booster. In our Eclipse planning system, we have AAA, which is fast, but not very accurate. And we have Accuras, AXP, so which is very accurate, but kind of slow and requires a lot of GPUs. So what we did was here, we look at the AAA dose, and we look at the patient's anatomy, CT. We trained a deep learning model to boost the dose accuracy from AAA level to the AXP level. And if you look at gamma passing rate, right? We use 1% here to just trying to see how tough, it's tough for the model. So if you look at the original AAA, the pass rate was only 86%. Now with this AI booster, it becomes 98%. For 1%, 1 millimeter, 98% pass rate, meaning these two dose distributions are essentially identical, right? This is for lung cancer, 120 lung cancer cases with different energy, different treatment modalities. So this is quite general. Another interesting work is to optimize full pie treatment. or CyberLife. So we see a strong analogy here between AlphaGo and CyberLife. So for AlphaGo, it tries to find the optimal next move in order to win this game. For CyberLife, when you try to optimize the sequence of the CyberLife, we try to find what's the next move of this robot for the best treatment of this patient, right? We see a strong analogy between the two. So that means we can use AlphaGo type of algorithm, AI algorithm, to optimize the CyberLife treatment. So we're working on that. We call this kind of work BOO, Beam Orientation Optimization. Deep BOO is the name of this model. This is some progress we made. Essentially, we can get a good plan now. So, like I said, we have done a lot of work, but I thought I only have time to share with you a few examples. And we have about 10 minutes for questions. Thank you very much.
Dr. Jiang, I had a question regarding the initial development of the technology. As we saw the graphs and charts shared by Ben, that there's a segment of diseases which are purely treated and diagnosed by the residents, and there's a percentage of contouring specifically done by residents. So my assumption would be that there is a segment of disease which can be treated at a lesser expertise level than to be treated at the higher expertise level. Would it be a better strategy to develop the technology in order to target that segment first and then come up with the result in the real time, in the real practice, and then further take it to the next level or the next stage of targeting complex diseases?
I agree. So like I said, we're working on so many different projects. Some of them are what you're talking about, right? So like I said, when I look at the survey results, I was very interested in that. So I don't know if it's okay to share again the survey results.
Sure.
So for example, for contouring, you have all kinds of people doing the contouring, right? You have physicians, you have residents, you have therapists. You could have a physicist too. If you go back to the early part of the survey, right? You have attending, 40% of attending. Then you have 33% contouring work done by residents. Then you have 20% by done therapists. So apparently the quality of the contours is not going to be the same among all these groups, right? Assuming attendees are better trained than the other groups. So AI actually can be very important here. AI can learn from their attendees and then can help residents, help therapists, physicists, dosimetrists to do the contouring here. Not only to improve the efficiency, also to improve the quality of the contours. So I think this is just one example, but I look at pretty much everything you showed us here. I say, oh, AI can help here. AI can help efficiency. AI can help the quality, like target, for example, contouring the target. It is very challenging, sometimes, and also it requires a lot of expertise and experience. And also it takes a long time, right? You see here, it takes like head and neck takes like more than an hour, more than 2 hours. Someone is saying something.
Let's see.
It's Ricardo.
Okay.
So apparently AI can help here too. Not only, like I say, it's not just simply to improve efficiency, which is important, especially in Latin America, because when you have a shortage of the staffing, right, you have a lot of patients waiting for the treatments. Efficiency is very important, right? Efficiency actually is equal to quality too, because if you can treat more patients with AI's help, then the quality of treatment for each patient is going to be improved too, right?
Yep.
So then for each patient, the quality of the treatment campaign.
Ben, can you go back to the contouring slide, please? So I was looking at your slides, and in relation to the Go game, AI Lee and then AI Go would learn from the players initially. So because we teach them the basic rules, and then it takes the practices of the players and learns the game. My question would be that 73% of these cases are being contoured by attendings and residents, not necessarily these clinicians or early clinicians have the right practices of contouring. So AI would be learning from the cases and the data bank, which will have 73% of these practices too. Does that bother you that AI might pick certain practices which it wouldn't have picked if it was observing only high-end clinicians or the chair of the department?
Very, very good point. So we actually have a similar problem even here in our department or in US, right? Not every, even if AI is learning this from physicians only, from attendees only, but not every physician, every attending is the same, right? Someone has more experience than others, right? Someone are much more junior or someone are more responsible, more careful, different personality, different philosophy, many factors contributing to the final quality of the contours here, like the targets, right? So what do you do, right? That's a very good question. We are working on this. Of course, you can always manually select, okay, I just want to get the most famous or well-known doctors to do this contouring. Maybe that's one way to do it. Another way is to have AI learning what is good, what is not so good, automatically. Then we call that self-involving. So AI can self-involve. You give it the data, and then train itself, and then you find out, okay, this part of this group of data sets are not so good. I'm going to filter them out gradually. We have more patients. The model will become better and better because the quality of the data will become better and better, right? So that's an ongoing research project if we want to make it automatic. But it's probably easier to make it just manual. But again, I don't know how it's going in Latin America, but at least in US, physicians are quite confident or arrogant. Everybody thinks I know the best for my patients, right? And even though you are more famous, you are more older, much older than me, but I don't want to listen to you. I don't want you to tell me how to treat my patients. I know how to draw this target. So how do you deal with that kind of situation, which is not uncommon? I have seen this a lot, right? So one way is, like I said, okay, in that case, we're going to provide you an AI tool that will draw the contours for the targets exactly in your way, right? So then, in the meanwhile, we also give you the menu of other people's, AI models, like Anderson's, Stanford's, Southwestern's. You don't have to use it, but maybe at some point you feel, okay, I'm not very sure about this patient. I want to see how other people handle this target, right? So then you can just click a button, it will show you the results. By doing that, I think in long run, you probably will learn from other people and then you will converge to their style. I think most people probably will do it that way. I personally think this is probably the way to go. I have a lot of physics colleagues. Like I said, physicians are arrogant, but honestly, a lot of physicists are arrogant too, because they believe, okay, I train an AI model, every physician should just use it. Don't argue with me. This is the way we should come to the target. AI tells you this is the way. Just use it, right? I think that's a very arrogant attitude, which is not good for the deployment of AI in clinic practice. I think we have to respect the fact that there is an art part of medicine, right? You have clinical guidelines, which gives you the floor, but there is a big room for physicians to use their own judgment, based on their experience, their training background, their instinct, their even their culture, their philosophy, because sometimes it's a matter of how to trade off between the toxicity and the tumor control, right? So there is no ground truth there, right? So I don't think AI should tell physicians what to do. We should more like provide a tool to help physicians do their job better, faster, safer, right?
Just one last question, and then I would require you to help me on this. So, in surgical practice, often you see a lot of surgical anatomy, which is new. Sometimes there's an anomaly, and you're seeing it for the first time. 2 arteries or 3 nerves. Do you face such problems in radiation oncology?
I think it's rare, but it could happen, right? It's kind of very rare cases. Then AI, typical AI doesn't help because AI needs data to train, needs a lot of data to train the model, right? So, but there is a solution for that. So for this kind of very rare cases, what you can do is you can have an AI to search a big database. When that happens, when you see like a very strange case, if there is a big database, let's say patients treated at UT Southwestern in a history of UT Southwestern, as long as the case is in a EHR, electronic records. So maybe AI can find out a similar case treated here 10 years ago by someone else, right? And then we'll generate a report for you automatically. So you can use that as a reference. At least you knew, okay, in that kind of weird situation, we had a case like that before. They prescribe this kind of drug, this is the outcome, and maybe I can learn something from that, right? So that's one way AI can help in that kind of situation. Right?
It's 6 o'clock.
Dr. Jiang, I'm part of a large WhatsApp chat group with over 200 medical physicists in Latin America. And just the other week, there was an interesting conversation that came up about AI. And so I'm going to try my best to represent the group in some of their questions. One concern was that a lot of the AI development is happening in the United States or in developed countries when we're making these fancy algorithms. But is it going to be representative of the patients and the kinds of cases that we treat here in Latin America?
So very good point. That's another very good point. That's another thing we're working on right now. So that's related to we call data heterogeneity. So it's not just between US and Latin America. It's even within developing countries. You develop a model, you train your model here. Does it work for your labor hospital? We don't know, right? The technologies, the patients population can be different, and also the technology can be different. The imaging scanner can be different, machines can be different, physicians can be different, right? There are a lot of heterogeneity in the data sets. So right now, a lot of people, most people I would say, are thinking of developing a general model, a model that works for anybody, anywhere, anytime, right? To me, that's impossible. That's too ambitious. So this is what people are thinking. For example, this Google work published on January 1st of this year in Nature. That's the breast cancer screening paper. They developed a model using 2 UK data sets. And then they tested on 1 US data set. And then they say, oh, that still looks good. So they say, okay, the generalizability is good. I actually, in Twitter, there were like Yang and those guys had issues with this work. Google is very good at PR, right? So this work caught a lot of media attention, but a lot of people saying, oh, this is not good because this work has issues, like this one, right? For example, is this model going to work in Latin America or in other countries or in other hospitals, other hospitals in US? We don't know, right? So our strategy, our research right now is trying to solve this problem using a concept called commissioning. We're not trying to develop a model that works for anybody, anywhere, anytime. The idea is that when we deploy the model, we develop here, right? We will deploy the model, let's say in Latin America, in one of the hospitals there. We'll look at your data. We're going to automatically adapt the model to your data, to your patients, to your physicians. This is just like when you get a planning system. You don't use it directly because your machines can be different from other people's machines. You're going to do some measurements. You're going to commission your planning system to your machines. So you're going to have a planning system that is different from other people's. And we want to do the same thing for AI model. You're going to have an AI model that is different from people use somewhere else, right? So we have done some work along this line to demonstrate this concept, which works quite nicely. So we have not published any work yet, but we have, like I said, a few projects showing very good results with this concept.
And as maybe my final question, so Rayos Contra Cancer is very happy to be partnered with MAIA Labs, and we want to help to introduce AI safely into Latin America. And as a center that may be watching this video, or someone who sees this video who is in Latin America, what are some things that they should think about if they wanted to participate in an AI study or collaboration?
So like I said, one of the mission of MAIA Lab is to empower physicians, clinicians, especially those with limited resources. I strongly believe that's where AI is going to make the biggest impact in healthcare. You know, we're not trying to say, okay, this is going to, like what Google has been doing. This model is doing better than physicians in screening breast cancer. So eventually we're going to replace physicians, right? So that's not what we're trying to do here. We're trying to say, okay, we train a segmentation model here, and we want to see if it can be useful in hospitals in Latin America to help people to solve their problems, like too many patients, too few physicians, these kind of problems. I think this kind of work will really make real impact quickly, right? So we welcome collaborations from hospitals in Latin America or anywhere. If you're interested in working with us, we'll be very happy to test our models, to deploy our models in your hospital, see if it's going to help you. And it's research, also it's some real clinical implementation work. We don't want to just stop our work after publishing papers. That's another paper on your list, on your CV. No, that's not so important to us. We really want to see if this work is going to help patients. So any ideas, any interest in working with us, please let me know. I don't know if if you search Google, for example, MAIA Lab, MAIA Lab, you should be able to find our webpage and our contact information there.
And I'll make sure that all the participants, everyone who participated in the AI study has contact information. And we have a few of our other supporters from Latin America on this call too. So we'll be in touch with them afterwards. And thank you so much for taking the time. I know you're doing a lot of important things, but hopefully all of us will leave today with a better understanding of artificial intelligence, radiation oncology, and the future of improving patient care.
Thank you. Thank you, everyone.
Thank you.
Thank you, Dr. Jiang.
Bye.